So we're going to start with trach care. Now keep in mind, if you are doing this skill on a live human being, now this skill off, is two separate skills. You are going to do trach care, and then you are going to do trach suctioning. On a live human being, if they actually needed suctioning at the same time that you needed to do trach care, you would start with suctioning and move to trach care after you did the suctioning. But I'm starting with trach care because it is the more involved skill. Okay?
Okay.
So just remember that on a live human being, real person would, every time they breathe, suction them first and then do trach care. On this person, we're doing trach care first. Now, what is the equipment that you are going to need? I'm always going to have to assess, so I'm going to need at least a stethoscope. I need, if I can possibly get it, a pulse oximeter. I can assess someone's respiratory status with reasonable accuracy without a pulse oximeter. How? It's really easy. Yeah. Are they blue or are they not? If they're blue, you got a problem. If they're not blue, you don't. Generally speaking. But that's not going to tell me that their O2 sats are 88 versus 94. So if I can get a pulse oximeter, I would like to have one. I'm going to need a trach kit. Make sure you are aware of what is in your trach kit because every manufacturer is different with what is in the trach kit. What should be in there is a sterile field. You should have also a set of sterile gloves. I always encourage you to bring an extra set of sterile gloves. A, in case you contaminate. B, in case the ones that are in the kit don't fit. Because you never know until it's way too late. You should have 2 or more cotton-tipped applicators, also called Q-tips. You should have a wire brush, which I call the bottle brush. And you should have 1 or 2 pipe cleaners. You will also have a set of ties, which are the very, very last thing you're going to use, but you will have a set of ties in there. You should have a drain sponge. The only difference in a drain sponge and a regular sponge is the drain sponge is cut in the middle. Now, keep in mind, if you do not have a drain sponge, can you take a 4x4 and cut it in the middle? No, you cannot. Because it will allow fragments. When you cut it, it will allow fraying that will go directly into the stoma. So you do not want to cut a 4x4. Get a drain sponge. They have sterile drain sponges in individual packages. You can get one. This is the last part. It's not done under sterile procedure, so you can wait to go get that after you're done and bring it back in. And then you should have about 4 4x4s. You may need more, so it may not hurt to grab an extra package of 4x4s, but it is not required. All of those things should be in your kit already. Some of your kits will also come with normal saline. Some of your kits will also come with hydrogen peroxide. The one that we don't use pretty much at all anymore is hydrogen peroxide. Now you can use hydrogen peroxide to clean this part of the body because it will dry out the skin a little bit, but it won't really damage the skin. You do not want to use hydrogen peroxide around the stoma because it will dry out the airway itself and it can cause coughing, which will cause increased mucus production. So I want to avoid any type of hydrogen peroxide here. If I have it, remember, it is only going to be used down here in this location. The other piece of equipment that you are going to need is protection. You need some type of eye protection and some type of nose and mouth protection. Now you have choices. You can either use goggles and a mask, or you can use a mask with a face shield. Either works. If you have glasses that are not little tiny wire-rimmed glasses, you can actually use your glasses. I don't encourage you to because you're going to be cleaning snot off of your glasses if you do. But you can choose to do that. A lot of people that wear glasses prefer the mask with the face shield. But the reason that you are going to need those is when you are dealing with a tracheostomy, you are going to induce coughing. No matter how you do it, you are going to induce coughing. Tracheostomies by nature have increased mucus production. So when they start coughing, they're going to cough up mucus. Now, what can they not do that you can?
Talk.
Oh, they can talk.
Oh, I didn't think we want them talking.
I don't want them to talk, but they can talk. But they can't cover it. Because what do we train our kids to do from birth?
I don't know.
Cover their mouth. Well, where are they coughing from? Right here. So they cover their mouth. That's great. What happens? Mucus flies right out of there. And I can say my former boss is the germaphobe king of the world. He was doing trach care in Chekhov on a live human being, because we did them on live human beings back in the day. And he was doing his trach care, and he had forgotten to put on his mask. And he was cleaning, and the patient coughed, and a wad of phlegm hit him right on the lip. Not inside the lip, but right on the lip. And he was in Chekhov, and he was not going to fail that Chekhov if it was the last thing he did. So he spent the rest of his Chekhov just like this. And he did not move. And I asked him how many bleach swipes did he use afterwards, and he was like, well, it took me a couple of weeks to grow my lip back. I thought, okay. So you need something to protect yourself. That is extremely important. I will not make you wear goggles for Chekhov or your mask for Chekhov, but you do have to tell me I'm going to place goggles and a mask, or a mask with a face shield or whatever, when you do your Chekhov. So I have my water or my saline. It has to be sterile. If it is opened, what do you have to do with the bottle? I'm going to have to lip it once I open it. What do I have to do before I can use the bottle? If it's already opened. Before I lip it, before I open it, when do I know I can use this bottle?
By looking at when it was opened.
Exactly. I'm going to have to see that there is a date written on here somewhere, because I can only use this for 30 days once it has been opened. So if there is nothing written on here, if there is no date and initial on here, I have to throw the whole bottle away and get a new bottle. So check your labels to make sure that it is, in fact, because the expiration date that is on the label is for when it is sealed. Once it is sealed, the expiration date changes, because we can't guarantee sterility after that, because it is being opened and closed and opened and closed. So I want to check my bottle. When I lip, when I pour, when I do anything with the bottle, put the label in your hand. That way when I lip and it drips down, it will not ruin the label in any way, shape, or form. Now then, and it's nice to have a trash can. It is not required to have a trash can. Your patient's chest, if they are compliant, can be your trash can. And that's perfectly okay. So the first thing I'm going to do is I'm going to check and make sure I have a doctor's order for trach care. Trach care is typically ordered twice a day, so you'll have a BID trach care order. I'm going to come to my patient's room, knock on the door, introduce myself, identify my patient, make sure that they're comfortable, that they understand what I'm getting ready to do. I am first going to establish communication, because I don't want them to talk. It's not that they can't. They can. All they have to do is close the trach. Well, if I'm working with a sterile field, I don't want them to put their hand over the trach. So I'm going to tell them, if you need me to stop during this procedure, I want you to raise this hand and I will immediately stop. Now, why that hand? It's away from my sterile field, so I stay safe. They stay safe. So I want them to understand. Raise that hand and I will quit. I am going to raise my bed to a height that is comfortable for me. I'm going to raise the head of their bed very slightly, just so that I've got gravity working on my behalf. If I want secretions going, I want them going downward, not upward. How high it goes doesn't matter, but I want them to have some angle. So then I'm going to tell them that I'm going to expose them. I don't have to expose a lot. I do want to expose the top part of their chest, because a lot of times this little drain sponge that they have won't catch all the secretions, so they will get secretions down here. So I'm going to tell them I'm going to expose them. I am going to cover them up with some type of waterproof covering. It can be whatever you've got handy. These are great. These are what we call chucks. They're awesome. If you don't have a chuck, you can use a towel. If you don't have a towel, you can use a pillowcase. We don't really care. Just use something. If they have supplemental oxygen on, I will leave it on until I am ready to become sterile. I can take it off. If their O2 sats are in their 90s, they're doing pretty good. I can take off their O2 sats, their oxygen, I don't really worry. If they're running about 90, like 90, I'm going to leave their oxygen on until I am ready to get started, just to give them every bit of oxygen I can. I'm not increasing their oxygen. You'll hear about hyperoxygenation. That is only if someone is in acute distress. But if they're hanging out, basically at their baseline, I just leave it on until I'm just ready to do everything else. So, the first step that I am going to do is I want to assess my patient. Number one, remember what I said on a live patient. If I need to do suctioning, when am I going to do it? I'm going to do it first. How do I know I need to do suctioning? Exactly, I have to assess them. So the first thing I'm going to have to do is I'm going to have to assess my patient's lung sounds. I am going to put my O2 monitor on them, and I will probably leave it on them for the entire procedure. Why not? It's not in the way, it's not hurting them, it's not hurting me, so it's there, and I can glance down, and when it's 80, I know to do something. So, and I didn't put that back in there, but just a minute. I will go ahead and put my mask, my goggles, or my face shield on. I want a pair of gloves. Because this is how I keep myself knowing which hand is going to be sterile and which hand is not. You do not have to do this. This is my trick. That's all it is. It's a trick. So that I remember which hand is sterile and which hand is not. Because like most of our skills, ultimately you're going to wind up with one sterile hand and one non-sterile hand. And when they both look the same, it's hard to remember which one is which. So you make them look different. So anyway, I've got a glove on. I am going to now remove my oxygen. I am going to gently remove my soiled sponge. I want to look at this soiled sponge to see how much secretion I have, what color secretion I have, what consistency of secretion I have, and if there is any obvious odor. Now, I'm not sticking it up to my nose, but is there an obvious odor? And if there's a strong one, you don't have to stick it up to your nose to know it. Then I can throw it away. Now I'm ready to open my sterile kit. So I can do that. I am going to take my sterile field. Now one side's shiny, one side is not. Which one goes down?
Shiny side down.
Shiny side down, ideal world. What if you mess up and you put the shiny side up? Oh well, doesn't matter. Whichever side is up is the sterile side. That's the rule. Now remember, I want to go out and away from me to pull it back, because if I reach across to lay it down, I've just reached across my sterile field. So you pull it back towards you. Now I need to empty my kit. I will do that by dumping it. I want to dump it carefully because I don't want everything going everywhere. Now I can pour my liquid. I'll take my lid off, place it there. I'll have a trash can. I will lip it just a little bit. I am going to fill my large container up to at least halfway. I am going to fill one of my small containers up to at least halfway with either saline or sterile water. Either or works. If I know this patient has a lot of secretions, I can also, in the other small container, use a half and half solution of sterile saline and sterile water. But remember that that is only going to be for this area of the chest. I won't make you do that for checkoffs because that's the only place you need it. But you can do that. So I've got that poured. Now, I need to spread everything on my sterile field out. Can't do that without sterile gloves. If I've got an extra set of sterile gloves, yay, I'll use mine. If I don't, I'll use what's in the kit. The way I'm going to do that is I want to grab a hold only of the corner of one glove. And then I can figure out by touching the inner cuffs which glove it is. And I can put it on. Yes, I put it on over a glove. Oh well, guess what? I now have a green hand and I'm gonna have a clear hand. I am going to know the difference. Now I can do whatever I want. The last thing I am going to need are my ties, so I'm going to move them out of my way. I'm going to take my Q-tips and my bottle brush and put them in the small container of sterile saline. I'm going to keep my dried pipe cleaners somewhere close by. The next to the last thing I'm going to need is my drain sponge, and then I always separate my 4x4s because inevitably when I'm one-handed, they stick together. So they won't stick together now. So now I am going to have to lose one sterile hand because my next action is going to be to take my inner cannula out. With this type of mechanism, which is the most common type of mechanism we have outside of pediatrics, you have a locking device that you twist and you pull it out along the direction of the curve. The curve will direct how you pull it out. So I pull it out, I look at it to see how crusted over it may be. I want to get it wet, so I'm going to put it in the large container of sterile saline. Now, that large container, tell me about it now.
It's not sterile.
It's not sterile anymore. Exactly. So don't put anything that is sterile in that container. Now, I'm going to lift it out with my non-sterile hand. The only part I want to touch is the part that is already outside of the body, that is already never, ever, 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 ever sterile, or even that clean. And that is the white part itself. This part is the only part I want to handle because it's already as dirty as any of it is going to get, and it's going to stay that way. So with my sterile hand, I will first take my bottle brush. I will insert it into the cannula until I see it coming out the end, and you'll see that my hands are not together. You do not let one hand touch the other because one is sterile and the other is not. Now to remove it, I twist and I pull. And this is when everything starts spraying on you, which is why you're wearing a mask and face shield. I will look again and see, did I get all of the crusted mucus out of it? I only have to clean the inside because it fits immediately into that outer cannula, so you won't have buildup out here. But I have to make sure the inside is clean. If I'm seeing that there is more in there and I need to dip again, I can. I can dip this in the non-sterile water because it is not sterile. This is not sterile. That water's not sterile. The only bacteria that you are touching are their bacteria to them. So it's less likely to make them sick. If I needed to dip this again, I can do that again in the non-sterile water. And I can do exactly what I did before. Insert until I see it coming out the end. My hands do not touch. Pull it back out while twisting. And see if it is clean. If it is, I can now toss my bottle brush because I'm done with it. If there are water droplets that I need to get rid of, I can tap it over the dirty water. Now I am going to dry. With my sterile, clean, dry pipe cleaner, I'll do exactly the same thing. Insert until I see it coming out the end. Hands not touching. Twist it out. The difference is this is a one-time use. I can't go back and do it again. So I have to throw it away. If I need another one, I have another one. Insert it until it comes out. Twist and pull back. I look at it, it is now dry. I am going to insert it back into the tracheostomy. Now when I do that, I will start that at a 90-degree angle just until I enter the hole. And then again, I am going to allow the trach itself to direct where to go. I can't force this in without causing pain. It is going to require that I turn it downward, and it will almost slide in by itself. And I simply twist it until it clicks and locks in place. Now their airway is secure. It is cleaned and it is secure. Now I still have more cleaning to do, but I don't have to worry so much about my patient having problems with oxygenation. So what I'm going to do next is I am going to clean the stoma. The stoma is what I am going to use my Q-tips for. So I will take a Q-tip. I want to stabilize my flanges. I'm not moving them because the more I move them, the more I will induce coughing. So I am going to hold the flanges. I will go from the outside inward on a single swipe. Again, this is a one-time use thing, and I throw it away. I did the underside. Now I'm going to have to do the overside. Same thing. I am stabilizing my flange. I go from the outside inward and throw it away. That's all the cleaning that I have to do on the stoma itself. We don't have to dry it. We haven't gotten it that wet. So it's done. The next part is if I need to clean the flange itself, because the flange itself has become dirty, then I make what I call a wonton. I just fold it into quarters, fold it into diagonals. I can dunk this in what?
Sterile water.
Sterile water. This is sterile. This small container is sterile. So I dunk it in my small container. I would squeeze out excess because I don't want a bunch of water running down the throat. And then again, I will stabilize and clean away, one-time swipe on the outer flange. I can do the same thing, dunk in sterile water, wring out any excess that's there, stabilize, wipe away, so I start toward the center, and in this case wiping toward me, because I always start at the center. One time, throw it away. Flange is fine. I do not have to dry it. Now what do I need to clean? I need to clean their chest if it needs to be cleaned. And it usually does. So I do the same thing. I am going to wet, squeeze out excess. Now here's where you have to be really careful because I don't want my gloves to touch my patient. Because if I do, my gloves are no longer sterile. So I will pat outward, rub it one time away toward. It's a one-time stroke from away from me toward me, and then throw it away. This is why I say sometimes you need extra 4x4s because you may have to do that several times to loosen the secretion. If they don't have a lot of secretions, one time is fine. But once you have cleaned their skin, the last part that I need to do before I redress them is what? What do I need to do to the skin? I need to dry it. How do I dry skin? Pat it dry. Again, I start away, and I pat toward me, and throw it away. My sterile part of this procedure is now complete. While we would love to figure out some way to put this on sterilely, it is not physically possible. If you can figure out how and you can patent it, you can probably retire before graduation. But we've been working on it for 50 years and we ain't got it yet. So, we're going to place this as cleanly as we possibly can, but it is not sterile. Again, I want to stabilize that flange just because I don't want to wiggle it. The more I wiggle it, the more they cough, the more chances I'm going to get phlegm in the face. So I want to stabilize, place this underneath my flanges, and pull it up.
You can use both hands?
You can use both hands. This is not sterile. Now, what I have not used are my ties, and I will not make you do that on checkoff. However, the ties are the very last thing that you use on a real patient. I don't touch the old ties until I have the new ties tied and in place. Because I don't want to take those old ties off, and even though there is supposed to be an air cuff holding this tracheostomy in place, I do not want to guarantee that that cuff is going to hold it there. So what I am going to do instead is leave this here. We only change ties when we have to, if they are soiled. If they're not soiled, we may leave them for several days. So once they are soiled, I will place this underneath, and I'm not really going to because my fingers are simply too fat. I will raise their head. Bring it around the other way. Bring it back around. And if I am going to use ties instead of the nice Velcroed stabilizers, I am going to tie it in a square knot. Why?
Easy to get it back off the next time, I guess.
If it's in a square knot,
So the patient can't take it off?
exactly, so that I can't get it back off.
So you're
Because
gonna cut
I,
You have to cut it.
I'm going to have to cut it the next time, absolutely. I do not want my patient untying this for the same reason. I don't want to take off the ties until new ties are in place because I don't want them to cough it out. Now, do you have any questions about trach care itself? This is just the cleaning portion. Now, in all reality, while you are doing this, at some point, if you happen to work in a facility where there are lots of trachs, you will probably encounter someone who coughs their trach out. The whole thing. Every bit of it comes out. It's not the end of the world. If this is an old established trach, if it's been there for a while, think about those of you who have ear piercings. Okay, if you've had your ears pierced for more than a year, and you take your earrings out overnight, can you put in new earrings tomorrow? Yeah, and this is a big tiny hole that we're talking about. You can still put earrings in. Heck, if you take it out for about 6 months, after you've had your ears pierced for about a year, you can still put earrings back in because the hole stays put. So if this is a relatively old tracheostomy and they cough it out, it's okay. Don't put the old one back in. It's dirty. Go get a new one of the same size. And the trachs do have sizes. It's listed on the flange as well as on the inner lumen. You just go get a new one of the same size and put it back in if it is an old tracheostomy. If this is a fresh trach, you're in the acute care setting of a hospital and somebody had, for some reason, obstructive sleep apnea is probably the most common reason to have tracheostomies. But they had obstructive sleep apnea and had to have tracheostomy put in yesterday. And they coughed it out today. In this case, you do not put it back in. You call the physician immediately because it is new enough at that point that it should be placed in surgery so that they can do it under radiography and make sure that it is in place at the right depth, the right length, that there is no swelling, that you are not scratching the trachea itself while it is being placed. So if it's new, you call the doctor. If it's been there a couple of years, just go get a new one and put it back in. In order to put a new tracheostomy in place, you must have an obturator at the bedside. What the obturator is a solid device, and I don't know if there's one over right here. No, there is not. They were up there. But it is a solid device that will go in the place of this. You take this part out, the inner cannula out, and the obturator goes in. Because what the obturator is it has a rounded end right here. Because this is sharp. If I'm trying to shove that into their throat, yeah, that's probably going to cut their trachea. But that rounded nub will not. So you put it back in place, take the obturator out, and then put a new inner cannula in. If you'll give me just a minute, I will do tracheostomy suction. No questions? Yes, ma'am. That is an obturator, yes. If you want to bring it up here, I'll show it to you. For viewing purposes. This is what an obturator is. What an obturator is, take this, and this one doesn't actually fit. Well, I can make it fit, maybe. You will put it in and it will come out the end like that, and you see how it is a rounded bowl. And yes, you do have to have an obturator that is the same size. This is a 6, this is an 8. It's written on the end what size it is. But you make sure you have an obturator the same size. You just insert it like that. It will come out the end, and you can safely insert it without scratching the trachea. Then you just take this out. You put this back in place, and you have a safe tracheostomy. Do remember that as long as the obturator is in place, they can't breathe. So don't take too long. It is a solid piece.
So for skill, we're doing the care and the suction?
You're doing the care and the suction, yes. As two separate skills at the same time. You'll do your trach care, and then you will get your stuff out and do your trach suctioning. Now, okay. So now for tracheostomy suctioning. First and most important piece of equipment to have for tracheostomy suctioning is suction equipment. So I'm going to make sure that I have my suction equipment set up. And guys, even though the suction equipment in this building works, please don't do any suctioning because I don't actually know where the suctioning goes. So I don't know that it ever gets cleaned out. What's in it may have been in it since we installed it. So don't actually test it or anything, but it does work. You can turn it on. When you are going to do tracheostomy suctioning, you are going to turn this to regular, and you are going to turn it between 80 and 120. The dial itself will go up between 80 and 120. I'm going to test it to make sure it works by doing that. If I feel it sucking on my finger, it works great. I'm also going to, as always, I'm going to check my orders, make sure I have an order for tracheostomy suctioning, how frequently it is ordered, when the last time it was done. I am going to come to my patient, I'm going to explain to them what I am going to do, that I am going to do tracheostomy suctioning on them. I am going to determine if they need it. How? I'm going to assess them, so I'm going to put on my stethoscope. I am going to listen to their airways. If they need suctioning, where are we suctioning? What are we suctioning? the tracheostomy area. We're going down into the carina. So where do I really need to focus my listening? Upper airways, exactly. Even if they have junk in their bases, I'm not suctioning their lungs. This is the only part I can suction. So this is where I'm really going to focus. Now I'm going to listen to bases as well. But I really care about those upper airways. I want to know what they sound like. I am again going to have my pulse oximeter. I'm going to place it and see what their O2 sats are. In this case, it's probably going to be lower. They're probably not going to have O2 sats of 95% or 100%, or else you wouldn't need to be suctioning them. So in this case, I am leaving their oxygen in place right up until I am ready to do it, and I will replace it as soon as I get done. Because they need every bit of oxygen I can give them, because they're already having problems breathing, or I wouldn't be here doing this. So again, if I have trash, that's great. It's not 100% necessary. You can have trash at the bedside in a bedside can. It does not have to be biohazard. The only thing that's going to be biohazard is what is going into your suction itself. So that's, whatever you've got is fine. I do still need my mask, my face shield, whatever is going to protect my mucous membranes. This is going to be another skill where I'm going to have a dirty hand and a clean hand. So again, I cheat. I make sure I know which hand is dirty and which hand is clean, and I do that by making them different colors. I am going to need a suction kit. You need to again know what is in your suction kit. Your suction kit should contain a cup of some sort. It should contain sterile gloves, and it should contain the sterile catheter. And that's probably it. That means I'm going to need something to fill up the cup itself. This is not in here correctly. We prefer sterile saline, but you can use sterile water. So same rules apply. I'm going to check the date that it was opened. I'm going to check that initials are on there. Otherwise, I am going to get a new bottle. I will date and initial it, break the seal, open it. If this is an old bottle, I am going to need to lip it before I use it for cleaning purposes. So I have that handy. I will open my sterile kit. I need what is inside the kit, not this itself, so I can get rid of this. Just to get it out of my way, because I see a lot of students when that clear plastic tries to close on, they're going, oh my God, what do I do? Just move it. It's not that important. Now, I will take my cup, and I can only hold the cup by the outside because the inside is sterile. So I want to open it, and I will sit it down. Now, I will lip my bottle. I will pour my cup full of water. Or saline. Now that that is done, I am ready to become sterile. Now, I know I'm going to have somebody, when they get to their kit and they open it and they go, oh my God, my sterile gloves, I can't reach them because they're on the bottom. What do you do? My sterile gloves are on the bottom. What do I do? What has to stay sterile other than the gloves themselves?
You feel?
Hmm?
You feel?
Not so much. I'm going to be done with my field here in just a second.
The catheter, but not
The catheter, exactly. So I can pick up my catheter bag, as long as I make sure not to dump it. What's in there has to stay sterile. But the bag itself doesn't. So I can move my bag. I just want to make sure that the opening stays on the inside so that I don't screw anything up. Now I can reach my sterile gloves. Okay. Now, I never touched the outside of this end. I touched the outside of the bottom end intentionally so that I could get a hold of this. This has been stored in a cold area. It's been stored in a cold storage. The colder this gets, the stiffer this gets, and I want it to be bendable. So the first thing I want to do is stretch it out, twist it around a little bit, loosen it up. Now I am ready to hook it up. Now my catheters, my suction catheters, have an on-on switch, an on-off switch. The hole is my on-off switch. If the hole is not covered, there is no suction in the catheter. If the hole is covered, there is suction in the catheter. So I'm going to be touching that hole and that green part with the hand that is going to be non-sterile. Now right now both of my hands are sterile, so I can touch it with anything I want. But it is not going to stay that way. And now is when I lose that sterility. So I am going to take my suction. It's already turned on. I already know it works. I'm going to hook it up. I want to push it together and make sure my hands don't touch. Now I can unfold this, and now my green part is no longer sterile because I am now ready to use my on-off switch. I want to test my catheter itself the same way I did the suction itself, by covering it up, and see if water goes up in it. If it does, it works fine. So now I am ready to remove my patient's oxygen, because remember, I have left oxygen in place for as long as I possibly can. I am going to insert this. This should go about 1/4 inch to 1 inch past where the tracheostomy ends. That just takes memorization of the fact that most of your tracheostomies range between 4 and 6 inches, depending on the size of your patient. Average patients, they're about 4.5 inches long. So I'm going to go about 5 inches into my patient. Another big trick is when they start coughing forcefully, you've hit their carina. That's as far as you're going to go. The carina is what? What? I'm sorry.
Is that where it starts?
That's where the left and right bronchus branch from the trachea. So if you hit that, that's as far as you need to go. So I'm going to insert this. I do not want to cover my suction while I'm inserting it, because as soon as I cover my suction, what? I am taking away their oxygen. So I want to wait on this. So I will insert it until I reach the space that I want it out, and then I will cover and twist as I withdraw. I will stop to give them a chance to recover because I don't want to take away their oxygen. I will cover it again, twist while I'm withdrawing. I'll stop, and when I stop, everything stops. My hands stop moving. Let them recover, cover it again, and pull it all the way out. Once it's out, I look to see if I have secretions. I clean those secretions out. None of my passes should ever take more than 15 seconds. That means from the time I insert it until I have it out, 15 seconds is my limit, because I don't want to deprive them of oxygen. Now, am I done? How do I know? I need to assess again. I'm going to glance at their pulse ox. While I'm listening, I may, if they've been in distress, put their oxygen back on them just to give them a little bit more oxygen. I am going to listen again to hear, do I still hear gurgling? Do I still hear lots of secretions? I am holding this in my sterile hand, because what am I holding? I'm holding their germs against sterile. So I'm not mixing germs. It's them to them, and only them to them. Now I am ready to make another pass. So I will untwist this. I will remove my oxygen. I will insert this to the length that I want it. Again, about 5 inches. I will cover and start twisting to remove. I'll stop, give them an opportunity to recover. Cover again, twist to remove, stop, Give them an opportunity to recover, cover, and withdraw it the rest of the way. Again, I want to look, I want to see, is anything clear? I am going to clear this out, make sure that it works. Am I done? I don't know. What do I have to do? I have to listen. So again, I glance at their pulse ox. I may put their oxygen back on. I'm going to listen to them. If I need to, I can suction a third time. You can only do 3. 3 is your maximum. 2 for children, 3 for adults. 3 is your maximum. So in this case, she sounds great. Everything is hunky-dory. I'm done. So now what I'm going to do is dispose of my trash. So I will turn off my suction so that you can hear again. Take this apart. Put it away. I have a nice little trash bag right here for all of my really yucky trash. It's called gloves. I can throw this in the trash. Any trash I want. This trash, just trash. I can dispose of the rest. I get my patient back into a comfortable position. I make sure that they have their call light. I do make sure that their oxygen is back on. I want to make sure their oxygen sats are better than they were when I started. And it may take them a minute to recover. It doesn't necessarily recover all at once. But I want to make sure they're coming back up. They're breathing easier. They can talk more easily. Now they can talk if they want to. I'm done, so they can do whatever they want. If they still sound junky, I may tell them that I will be back in about an hour. But I'm not going to rush right back in. I want them to recover before I start this process again. Because this is hard on them. And they don't like it any more than I like to do it. So, any questions? Yes?
When we do suctioning for this deal, are you going to make us do it twice or 3 times, 2 times?
I will always ask you, are you done? And you should always tell me, I am going to listen again. But I will only make you do it once.
So, will you go over like when we can check off? Like we're not doing anything Friday. We can either come Monday or Wednesday of next week.
You can come Friday.
I thought you said we couldn't do it Friday.
Yeah, you said you had meetings all day.
I do in the afternoon. Do we have class Friday morning?
No.
Yeah, I do in the afternoon. I have meetings starting at noon.
So we have tomorrow, Friday, Monday, and Wednesday?
You have as long as you need, yes. Tomorrow, Friday, Monday, Wednesday. Hang on, let me double check my Friday schedule. Yeah, I'm good until noon. So from 8:30 until noon, you can come, practice. If I like what I see, I'll check you off then. Don't like what I see, I won't check you off then. I plan for this to be relatively informal. It'll still be a formal check-off, but I plan for it to be relatively informal as far as scheduling. I'm not going to make you sign up until the last day, because you need to be in here practicing. You need to handle this equipment. You need to get proficient with the feel of this equipment, and you're not going to do that if you're not in here practicing. So you can't come to me and you've never practiced before and say, I'm ready to check off. No, you're not. I will be in and out watching you. If I'm watching you and I say, you're doing a darn fine job, don't worry about signing up for check-offs, you're checked off. I will beg, plead, borrow, and steal from Miss Crick to see if she will do the same thing with me, if she will come in and help me watch you all practice and help check off, because she's helped check off with this particular check off for 2 semesters. So she may be able, and she has every right to do the same thing. Any teacher in this college has exactly the same right to do the same thing. If they come in and they're watching you and say, you're doing a really good job, as long as they'll come and tell me, you know what, Michelle did a fantastic job, she doesn't need to come back, I will mark you as a check off. Okay? Now, anybody that is left, toward the end of, toward midweek next week, I will find a day in the week and we will sign up for check-offs. You know, I may have to do it over 2 days because I am now, because we have canceled the full Friday checkoff, I am now at the mercy of the other semesters and their checkoffs. So we will work around their days. And it may be in here, it may be in 308, it may be in 306. We'll figure it out as we go. Any other questions? This is your last opportunity to ask. Well, until you practice.
Can the people who videotape it on Facebook page?
I don't, if you do not put it on, like, you know, America's Funniest Home Videos or something like that, I don't care. Or if you do and you win, you have to split it 50-50. That's the rule, okay?
Sorry guys, my phone so halfway through, but otherwise I totally would.
Michelle's video
It will be up on Collaborator or somewhere on Blackboard once John gets back to tell me where he put it. Yes. We should be in 311. Because it just takes more oxygen. So we just kind of set soft on it. Now, like this respiratory therapy, they don't go down there. Patients who are ventilated will go down multiple times. Remember that patients who are ventilated are having forced oxygen between sections. So they're getting more oxygen than we're getting this patient, so it's not going to be as distracting.
I feel like all of us should be together because that's my favorite.
Right, you've seen me do it over and over and over and over, but that's because they're getting forced air between every section. In this particular case, I'm not giving them forced air, I'm just giving them their regular supplemental oxygen.
Gotcha. There.
And I'm taking them, they're not, I'm taking their oxygen.
Cannula.
Yeah, they have no problem with that, so we stop.
As a class? Like after class, like go over the so it is still.
And it's the same thing, it's like I said, it's 2 it's for the same.
It is still even if their trach is old, and it is still, everything is the exact same, even if they have
And
no
you are
trach.
going to have tell you that it is not sterile. And that's because they are taught that it is not sterile. There is literature to support both sterile and non-sterile trachea. So they're not that's not how we teach it. Okay?
And that's probably why different facilities have respiratory therapy do it, and different facilities have.
Absolutely, absolutely, because they are taught differently. So. I have 2 answers for you.
I guess in our regular rooms, it doesn't say.
Yes, it's 11.
So hematology work is like, there are 14 people, no.
It's just not fun.
Unfortunately,